Good morning, and welcome to the National Kidney Foundation of Indiana's Kidney Corner. I'm your host, Dr. Wendy Kindig, and we are going to be discussing kidney stones this morning. So with me today, I have as a guest Dr. Amy Krambeck. Good morning.
Good morning.
Dr. Krambeck is a urologist with IU Health. And then we also are fortunate to have Randy Howard with us this morning, and he's actually a patient who's gone through kidney stone disease, and so we're going to include him in the discussion also, because I think it's important to hear it from not just the physician's perspective, but from somebody who's actually had to go through those experiences. I think that always adds something to the discussion. Now, before we start the kidney stone discussion, though, I did kind of want to talk a little bit about the distinction between nephrology and urology, because that seems to be a question that comes up not infrequently. So I'm going to start with Dr. Krambeck and ask her to kind of tell a little bit about urology and some of the things that are distinguishing for that specialty.
I think the easiest way to think of it is that urologists manage surgical issues that affect the kidneys, ureter, or bladder. So we're more of the surgeons involved in any condition there, whereas a nephrologist is medically managing these conditions.
Yeah, and I think that's probably the simplest way to put it. My training as a nephrologist did not involve any surgical procedures, but I did have internal medicine as my initial specialty, and then following that took subspecialty training in nephrology so that I was able to take care of adults with chronic kidney disease on dialysis, maybe after transplant, hypertension, and I did have some complex kidney stone patients in my practice that required some special attention or had kidney damage because of their stones, which isn't that common. Okay, and then I did also want to ask you, Dr. Krambeck, since women in nephrology are relatively low, about 10% of urologists are female, a little bit about that, why you think that is, and then also a little bit how you chose to go into urology.
Well, I think historically the number of women in urology have been low because urology is just not about kidney stones or kidney disease. It also focuses on other conditions that mainly affect men, such as prostate cancer, BPH, cancers of the external genitalia.
BPH.
I'm sorry. Benign prostatic hyperplasia, or enlargement of the prostate that makes urination difficult.
Just clearly.
So a lot of those conditions only affect men, and so there's more male patients. And I think that's why historically women have been shying away from urology. However, we do see more and more applicants that are female every year for the residency program. So I think it'll be more common if you're a man that's going to a urologist that you may have a woman as your physician in the near future.
Yeah. And what kind of helped you decide to go into urology?
So when I was growing up, I grew up on a farm and really liked working with my hands. We did all our own veterinary work, but I wanted to work with humans. So I went to medical school and focused on a surgery residency. But as I did my rotations, I really liked the urologists. They have a laid-back personality. They enjoy their job. They seem very happy, and so that's why I chose urology.
Okay. And is kidney stone disease one of your areas of interest in terms of your practice?
Yes. So I did a full urology residency, which was 6 years, and then I did a 1-year fellowship focusing just on the surgical treatment of kidney stones. So I specialize in kidney stone disease. That's the majority of my practice.
Okay. All right. I think we're ready to talk a little bit more about kidney stones now. So we're going to start out with just tell us a few of the statistics about stone disease, and then we'll see how Randy fits into that.
Okay, sounds good. So kidney stone disease is quite prevalent. It's about 2 to 3% of the general population will have a kidney stone at any given time. And throughout someone's lifetime, it's about 10 to 15% will experience a stone. And the prevalence is increasing as kidney stone disease is related to obesity and inactivity. And as our nation is getting larger, we're seeing more and more patients with stones. It's a 1 to 3 or 2 to 3 risk that a man is going to get a stone more than a woman. So men are at higher risk than women. And stones tend to recur. About 50% of patients who have had one kidney stone will have another kidney stone in their lifetime. And some patients, such as Randy here, have had multiple stones. How many stones have you had?
Actually, I've lost track. I've had, I think, at least 4 over the years.
Okay.
Yeah, every few years.
Yeah. So you would fit into one of the higher risk groups, I guess, which would be just your race and your sex. So let's talk a little bit about risk factors then. What are some of the risk factors that might make somebody predisposed to having kidney stones?
So Caucasians and Asians are at higher risk of stone disease than any other ethnic group. If you have a family history of stone disease, you're at much higher risk of kidney stone formation. And if we queried all patients with kidney stones, about 25% would have a strong family history of stone disease, meaning that their parents or cousins or uncles or aunts had stones frequently.
So Randy, do you have any of those risk factors? Other
Yes.
than obviously the male.
Stones run real strong on my mother's side of the family. Yes.
So how many, who in the family, I mean, what relatives would have
Oh, I
stones?
think my grandmother, my mother, myself, my sister, my brother,
Oh.
several cousins.
Okay.
Runs real strong.
Yeah, okay. So that's risk factors. So there's some additional risk factors that Dr. Krambeck's going to mention here.
Well, yes, geography is actually a risk factor. So people who live in more arid climates, such as the desert or mountainous areas, and then areas where it's extremely hot, such as the tropics, are at higher risk of stone disease. And there's actually an area of the southern United States called the Stone Belt, where people are at higher risk of stone formation than in the upper areas. Luckily, Indiana is not in the Stone Belt, so you're safe. Seasonal, there's more stones in the summer and the hotter months than there are in the winter. People with low fluid intake, so people who do not like to drink a lot of fluid, are at very high risk of stone formation.
And what would you say is a low amount of fluid?
Less than 2 liters a day.
Okay.
So if you go to the grocery store and you see one of those 2-liter bottles of soda on the shelf, that's the amount of fluid you should be drinking a
Not
day.
the type.
Not the type, but,
But
the amount. Yes.
Okay, just wanted to
Yes.
clarify that.
And if you sweat a lot, if you work outdoors or you exercise, you need to be drinking even more than that. Certain diets, high protein diets, are a real concern, especially when the Atkins diet was such a fad for a while. Those patients have really high protein loads, and that can exacerbate stone disease.
Any particular kinds of stones, or just makes it worse overall
Well,
if you have other risk factors?
that's a very good question. More likely uric acid stones, because a protein load will acidify your urine and make it quite acidic, and that promotes the formation of uric acid stones.
Okay.
A certain
You put some occupations down there that,
Yes.
looked a little unusual. So.
Yes, so astronaut probably does not affect very many people watching this, but astronauts are at increased risk because they lack gravity, and so when they're up in space, they don't have the gravitational pull. They start demineralizing their bone and excreting large amounts of calcium, and then they form stones. But occupations that would probably affect more people viewing would be truck drivers, anybody who restricts their fluid intake in order to not stop and urinate is at higher risk. So we have truck drivers, surgeons, they're at very high risk of stone disease, or anyone who actually works in an operating room because they can't use the restroom at a regular time. Factory workers, because of the same thing, they only can go to the restroom during breaks. Those are the type of people that are at higher risk.
Okay. So, Randy, did any of these risk factors seem to be related to you? Did you have low water fluid intake?
Well, not anymore. Maybe originally that might have been an issue, yes. Geography, I'm interested in that because my family is from Tennessee, so I'm wondering, does that fit in the belt
It does.
you're talking about?
It's on the edge of the belt.
Okay,
yeah.
it's on the edge of the belt, so most of my family lives there, so possibly that may be a factor as well.
Okay.
So
Okay. So let's now go on to how do you know you have a kidney stone? So what are the common symptoms that might occur, Doctor? I'm going to start with you, Dr. Krambeck.
So I'll explain them if you want to chime in at any time.
Okay.
So the number one symptom that you hear about most frequently is renal colic. And that's what you see on TV. If you see a sitcom or a show where someone's suffering from a kidney stone, they'll be in writhing pain. People who are suffering from a kidney stone attack are almost confused from the amount of pain that they have. They will be unable to find a comfortable position. They will constantly writhe around trying to get comfortable, and they can't.
That sounds familiar.
Was that your first experience?
It was, and I actually had shooting pain up my back on both sides as well. Yeah, so
Came on suddenly, or did you have was it a gradual onset? Or?
it was pretty sudden. Yeah,
Yeah. So so saying achy side pain.
That's minimizing it for
Okay.
sure. It's most people who describe it say it's the worst pain they've had in their life. Women who have had children and stones say the stone was significantly worse than childbirth. It's a very painful situation.
Now, might there be other ways that kidney stones could present besides the severe colic? In other words, could there be pains that indicate kidney stones but not be the typical colic?
Surprisingly enough, the severe pain comes from the smaller stones. So if you have a small kidney stone that is moving around, that's when you get the severe colic. But larger stones are more discreet. So people may have just a vague ache. They may just feel like they are more and more tired, just not feeling quite themselves, and then they get diagnosed with a very large kidney stone. So it can be much more subtle.
Okay. So on to the next symptom, I guess.
So if the stone is passing and it gets close to the bladder because the kidney is up in the back, the bladder's down in
Here,
the
I'll
pelvis.
show this picture, and we can come back to that. So,
And as the stone moves from the kidney to the bladder, it has to pass through the ureter tube or the small tube there, and that's where you
So,
get
yeah.
the pain. When it gets close to the bladder,
oops, can't get that. So,
it irritates
well, that's not
the
going to
bladder.
want to do it. Yeah. Go ahead. The pointer doesn't want to work for me, so go ahead.
As the stone gets close to the bladder, it can irritate the bladder and make you feel like you need to go to the bathroom frequently, often. Many times people get diagnosed with a urinary tract infection because the symptoms mimic a urinary tract infection.
Yeah.
Is that
Okay.
true? Did you
have some of that?
yes, and I'm looking forward. I actually had one stone where I got up in the morning and felt fine, but I couldn't urinate at all. It was apparently blocking my urinary tract. Right. Now the pain came later, but there for a few hours I just couldn't urinate. I couldn't figure out what was going on. So, yeah.
Okay.
Very true. And the next set of symptoms is nausea, vomiting, or the opposite, like you just feel bloated or maybe diarrhea. And that's because the brain isn't used to perceiving your kidney or your ureter. It's not normal nerve signals that you get from the brain. And the nerves that run from the kidney to the brain also run alongside the nerves that give signals from your bowels. So a lot of times the brain gets confused and you start getting these signals of a bowel problem. You can get the nausea, vomiting, you can get the diarrhea. Also, the capsule of the kidney has these discrete nerve receptors. So if it gets swollen because the kidney is blocked, that triggers a vomiting reflex.
Randy, did you happen to have any of those kinds of
I
symptoms with your
have
stone?
nausea, definitely, yes.
Yeah.
Never to the point of vomiting, but definitely nausea, yes. Yes.
And then, yes, a lot of times if you go to the doctor, they will look at your urine, and you should, 85% of the time, you'll have blood in the urine from the stone.
Now,
And
blood that you would see, or blood that you would see under the microscope? Blood
Rarely-
that the patient could see? Or
Rarely the patient sees it. The people that I find see blood in the urine when they have a stone often are on blood thinners. They take aspirin, Coumadin, Plavix, Xarelto, one of the many blood thinners that are available. And those are the people that often see it with the naked eye. Usually it's microscopic amounts.
And were you ever, Randy, ever to see gross blood in your urine with any of your stones?
No, I don't believe so, no.
Okay, so let's go on a little bit, talk about different types of stones, because we mentioned calcium, but obviously there are a variety of types of stones. So do you want to talk about that, Dr. Krambeck?
The most common stone is a calcium-based stone. And the calcium is mixed with another substance. So it's either sorry about that.
Yeah,
it's
we
either
have this fly problem this morning. Sorry. When we do this, it's because we're trying to get rid of the fly.
it's either oxalate, which is probably the most common stone, calcium oxalate. And I think there's a picture of one next. And that
so calcium oxalate is the dark one.
The dark black stone, yes.
Yeah.
The other type of calcium-based stone is calcium phosphate, which is right here. That's the yellowish type of stone. And a lot of times it's mixture of both. So you'll have mixed calcium oxalate, mixed calcium phosphate. Calcium phosphate can be broken up into two types: brushite, which is exceptionally hard and is much more difficult to treat, and then apatite, which is softer and easier to treat. Then what we're seeing more and more of currently is uric acid stones, because it's related to obesity and diabetes. So patients with obesity and diabetes have more acidic urine and form uric acid stones. And there's a picture of that too on the next. So they're generally orange, and they have a real distinct appearance. If you pass one, they'll be more of an orange color. It can be small and pebbly looking too.
And the other point about that is that they're often not very visible on the standard x-rays.
Right. So the plain abdominal x-ray, you cannot see a uric acid stone on that, but you can see it on a CT scan.
And then it looks like we get down to some less common ones.
Struvite stones are made from infection. They're not as common in the general population. And then there's some genetic disorders like cystinuria, primary hyperoxaluria. Those are rare genetic diseases that cause kidney stones. And then some drugs can cause stone formation. Certain types of medication can form a stone in your urinary tract.
Yeah. Now, Randy, are you aware of what type of kidney stone that you have?
I believe I've been diagnosed with the calcium. Yes.
Okay. Yes. Okay. And was that, I assume, since you had some procedures that removed stone, that they had analyzed one of the stones for you? So once you found out that, okay, it looks like you do have one, or you're still trying to be sure that you do have a kidney stone, how do you get evaluated for that, Dr. Krambeck?
Well, many patients end up going to the emergency room, so because of the severe pain. So they'll often get a full set of vitals. They may get some blood work looking at their kidney function. They'll probably get a urinalysis and a urine test or a culture looking for infection. And then the next step is, in the vast majority of cases, a CT scan of the abdomen, which would be a non-contrast CT scan, meaning that no dye is given in the vein to find the stone and diagnose it.
Now, I know sometimes now, because of the frequency of use of X-ray and CT scanning, there's been some concern about that. Are there other, like ultrasound, which does not have the radiation associated with it, even though it's very low amounts? Is that something that's utilized or is useful for looking for stone disease?
We're seeing more and more patients arriving with an ultrasound. And an ultrasound is safe. It does not produce radiation exposure to the patient. But there was actually a study just released in the Journal of Urology this month that indicated that it is not sensitive enough or specific enough to accurately treat stone disease. We're missing a lot of stones. Not all stones show hydronephrosis. So we might send someone home and say, you're fine, and they really did have a stone that required treatment. So yes, we're seeing people screened with an ultrasound, but when it comes to treating stone disease, my opinion and the opinion of others is that you really need a CT scan.
Okay. Okay. So do you recall, we'll do this one before we go on to the treatment, what kind of testing did you have initially? Was it a scan?
It was a scan.
And when they first determined you had kidney stone. So.
Exactly.
And if I could just run back to that for a second.
Sure.
So, it used to be a CT scan was a high load of radiation. So you could be up to 15 or 20 millisieverts, which is how we measure radiation. And you don't want to have more than 50 a year. Nowadays, they've developed low-dose CT scanners that have between 1 to 3 millisieverts. So that's the same radiation exposure as a plain abdominal x-ray. So we've gotten much safer with that.
Okay, that's good to know. On to treatment options. So that's really evolved over the years in urology, the ways in which that if the stone is unable to be passed on its own, how you can help remove those stones, and that's really evolved quite a bit. So I thought we'd go through some of that, and we'll share that too with Randy, what his experience is. But why don't you start and tell us what, start at the top, I guess.
So the good news for patients is 75% of stones will pass on their own. So only a small percentage or a quarter of stones will ever need surgical intervention. And so we do several things such as conservative management to help the stone pass. So we can give you medication to help with pain and nausea and support you until it passes. If you need surgery, then you're looking at the three most commonly performed procedures in the United States are shockwave lithotripsy, or SWL or ESWL, those are the names for short, and ureteroscopy and percutaneous nephrolithotomy. Sometimes it's called PCNL, PERC, PUL. Those are the different ways. And I think we have a picture of shockwave lithotripsy. So with shockwave lithotripsy, it's very attractive to people because it's an anesthetic, or sometimes it's done without anesthetic, just sedation, and you lay on a bed. They put these little water bags to your back, and then shockwaves go through your body to break up the stone. Then you have to pass the fragments. That's nice. The success rate is fairly low. So the likelihood...
Low meaning...
Yeah, so the likelihood of getting every little piece of stone out of that kidney is around 30%. So it'll be a quick fix, but it won't often render the patient stone free. And as surgeons, we want it to be perfectly clean, and we don't want you to have any more problems. So the other two options are ureteroscopy, which is where a small, tiny scope is inserted through the urethra or the penis and up through the bladder, up the ureter to the stone, and then a hair-like laser is used to laser the stone into small pieces, and then a basket pulls it out. And that works very well for smaller stones, but it does require a recovery period. You'll be out of work a few days, but generally it's around 2 or 3 days up to a week, and then you can go back to work.
And Randy, is that one procedure that you have been through?
I've been through both these procedures, yes. And the lithotripsy is true. It worked immediately, but a few days later, the symptoms came back, and it was either fragments or the residue from the procedure. I had to pass that. So that's a good news, bad news. I got rid of the stone, but you still have to get rid of the residue. And then the cystoscopy or the uteroscopy here, I had one of those originally, probably 30 years ago. And unfortunately, after they did my procedure, they said they couldn't find anything. So apparently I'd already passed it without knowing it. Don't know. But anyway, but they did put me to sleep, put me under sedation for both those procedures.
Sorry.
Okay.
And then the percutaneous nephrolithotomy is really for very large stones. That's the procedure I do the most of, and we make an incision in your back and create a tract using x-rays to the inside of the kidney to remove the stone. And that's a longer procedure. You're in the hospital a couple of days and off work for a few weeks.
Okay. So let's go on to talk a little bit about treatment, try to get that in treatment and or prevention.
So I would say if you've had more than one stone or a strong family history of stone disease, that you should undergo a full metabolic evaluation, and that's where we try to figure out why you're forming the stones, and we look at your urine. If you have low urine volumes, then you're chronically dehydrated, and you should be drinking between 2 to 3 liters of fluid a day. I would recommend water or light-colored liquids such as lemonade, Crystal Light. That has more citrate in it. It's better for your body. If you have high levels of calcium in your urine, if I can stress one thing, it's that you do not cut the calcium out of your diet. That was an old treatment, and we found that it actually increased stone formation. You should be on a normal calcium diet, and a lot of times you need.
Yeah, and I was going to say, but address a lot of people are taking supplements.
Supplements are a different
calcium
story.
and vitamin
Yeah.
D supplements, not what you're in your food. Would you comment on that?
Right. And if you have osteoporosis, you need those supplements. But unfortunately, a lot of people are taking it just because they think they need it, and they don't have a true diagnosis of osteopenia or osteoporosis. So if you're just taking that medication, we would have you stop the vitamin D, stop the calcium supplementation, and then get the calcium from your diet.
Yeah.
And then we ask you to be on a low animal protein, low salt diet. If you have low citrate or low urinary pH, we might put you on citrate therapy, which would be like a medication called potassium citrate, or ask you to get it naturally in your diet from fruits or lemonade or orange juice. A small percentage of patients have hyperoxaluria, which means they have too much oxalate in their urine, and we ask them to go on a low oxalate diet. Low oxalate diets are exceptionally hard to follow. So what I ask my patients to do is just to avoid the big four, which is spinach, nuts, tea, and chocolate. Those have the highest levels of oxalate, and if you can cut that out of your diet, it often normalizes.
Yeah. Okay. All right. So you're up to what on your fluid intake these days?
I am much above what's listed there on the chart. I drink water all day
Okay.
long. Yeah,
That's great.
make a point of doing it.
Yeah.
Yes.
Okay.
Yes.
Well, I think we're going to be wrapping it up. So thank you both very much for
Thank you for having
being
me.
with
Thank
me
you.
this morning and
Thank you.
discussing kidney stones. And I'm just going to highlight a couple things upcoming for the National Kidney Foundation of Indiana. The first being the gala, which is coming up October 15th. And we'll be honoring Dr. Sharon Andrioli, a pediatric nephrologist who's done some great work in her field. This is open to the public if you're interested in coming, because it's a great activity. It's a very nice evening of dinner, dance, and a silent auction. You're welcome to join us, and you can contact Abby Moore with that information. In addition, we have a kidney screening coming up on November 12th. And it's a 2-suite for your own good diabetes conference. This is open to the public, but you do need to register. And there's the number that you can register through, but there is free screening program at that time. And then again, if you have any questions, comments, want to volunteer, just whatever, here's the information to contact us, the National Kidney Foundation of Indiana. Appreciate you joining us this morning, and we'll see you next time.